Haemoptysis means coughing out of blood. Common causes of haemoptysis are lung cancer, tuberculosis, and respiratory tract infection. There are some rare diseases that may cause haemoptysis, such as Goodpastur syndrome, wegener's granulomatosis, pulmonary embolism, pulmonary arteriovenous malformation, and drug-related causes. Patients with lung cancer usually present with haemoptysis, cough, chest pain, low-grade fever, anorexia, and weight loss. There may be some extra lung manifestations such as Horner's syndrome, clubbing, proximal muscle weakness, and metastatic features. Diagnosis is usually made through X-ray, CT scan, FNAC, bronchoscopy, and sometimes pleural fluid study is done if there is associated pleural effusion. Common X-ray finding is homogeneous solid opacity. Sometimes cavitary lesion can be found if there is interlesional necrosis and bleeding. Tuberculosis usually presents with cough, haemoptysis, low-grade fever, anorexia, and weight loss. Sometimes there is history of TB contact. Diagnosis is confirmed by detection of acid-fast bacilli under microscope. Other tests that aid diagnosis are high ESR, positive tuberculin test, and characteristic X-ray findings. Inhomogeneous patchy opacities are characteristic for tuberculosis. Sometimes cavitary lesion, nodular, or infiltrating lesion can be found. Pleural fluid aspiration and study are sometimes done if there is associated pleural effusion. Raised pleural fluid ADA is characteristic of tuberculosis. FNAC is sometimes necessary that shows chronic granulomatous inflammation. Pneumonia or lung infection usually presents with short history of cough, high-grade fever, dyspnea, and rarely haemoptysis. On auscultation, there is bronchial breath sound over the consolidation area, and crepes may be found. Parapneumonic effusion may be found in some cases. Inhomogeneous opacities or consolidation are found on X-ray. Goodpastur syndrome is an autoimmune disease in which autoantibody production occurs against the lung and kidney basement membrane. Lung and kidney destruction occurs as a result. Typical findings are haemoptysis and hematuria. Antiglomerular basement membrane antibody is found in most of the cases. X-ray reveals coalescence airspace opacities. CT scan findings are ground glass opacities and airspace opacities. Kidney biopsy is usually confirmatory. Light microscopy shows crescentic glomerulonephritis, and immunofluorescence microscopy shows linear immunoglobulin G deposition along the glomerular capillaries. Wegener's granulomatosis is a rare form of vasculitis and is a multisystem disorder that involves the nose, paranasal sinuses, lung, kidney, skin, eye, and many other organs. Early nasal symptom is nasal irritation. Later on, nasal bleed, nasal crust, and nasal deformity occurs rarely. Lung involvement causes cough, haemoptysis, and dyspnea. Common eye problems are episcleritis and conjunctivitis. Arthritis may also occur. Hematuria occurs if kidney is involved. Skin manifestations are subcutaneous nodule and palpable purpura. X-ray findings are pulmonary infiltrating lesion, cavitary lesion, or nodular lesion. Biopsy shows granulomatous inflammation. Kidney biopsy shows features of glomerulonephritis. Pulmonary embolism usually presents with chest pain, dyspnea, and occasional haemoptysis. ECG shows right heart strain pattern. Raised D-dimer is suggestive of diagnosis. Characteristic echo findings are found in chronic pulmonary embolism. CT pulmonary angiogram is usually definitive of the diagnosis. Pulmonary ventilation perfusion scanning is sometimes done, and pulmonary angiogram is usually confirmatory and is rarely done, especially when interventional management is necessary. Thank you for watching.